The history of the standards and the accreditation model is professional-led, consensus-driven. The standards are developed by the North Americans through FACT, the Foundation for Accreditation of Cellular Therapy, and then from the European or /international side from JACIE. The requirements emerge from detailed discussions between practitioners, between the experts. There's also a significant public consultation as well. So these are not opinions of a select few, but this is a very open, I would say, transparent process, attempting to reach, as I say, an agreement on what the minimum requirements should be. What's becoming clear now is that the interest is from other stakeholders is widening, where previously it was something that was to preserve of the community. Now the interest in quality structures, safety measures, continuous follow-up, quality improvement. Other stakeholders being the manufacturers, being payers, being regulators. They're looking to something that exists and seeing the value in that as, again, another way just to give reassurance, to give some minimum indications of safety, of quality, etc. I think reassurance is probably the main word, especially at a time when these therapies are so new that we have so little data really, and certainly very little long-term data, that we're going to see how these progress. So the interest in a set of standards and an accreditation model has gone to a point where it's gone outside of the society, outside of the community, and is becoming valuable and recognized well outside that as well. So the standards themselves then, a lot of emphasis on staff in terms of experience and training, continuous training as well. A lot of emphasis on the installations, the physical structure that's set up. In the context of these new therapies, big emphasis on the multiple disciplinary team approach, which is making sure that everybody who potentially is important to delivering this care is involved. So this means good communications with your intensive care team, neurology service. It means having excellent data collection through your data manager. It means having a series of plan A's, plan B's, and indeed plan C's for when things don't go exactly as you expected. Again, we have many known unknowns and unknown unknowns in the context of these therapies. So really what you're looking for is seeing a team that's gone through a thought process, has taken decisions on how they're going to act in given circumstances. I'm thinking of CRS, again, of the neurological toxicity, and the multiple other complications that can be there. And that the preparation includes training, specific training, and then going back and checking how do they do when things don't go well, how they learn from that, and then they apply that in their practice as well. Other parts of, in terms of the structure would be the quality management itself, that there are written protocols, written procedures, data is being captured in standardized forms, that there are decision making is being documented and then being followed up afterwards. CAPAs are being performed properly. And then when you get into the very technical detail of actually administering these therapies, or the apheresis setting where the starting material is collected, again, the complexity of collecting from perhaps very sick patients requires perhaps an even greater skill level from the operators, a level of preparation in terms of using the equipment optimally. And then in the processing setting, specifically cryopreservation, again, that protocols are being followed, that these products are coming back on site from manufacturing, are being handled properly, the connection with the pharmacy. So this is not something that can be just managed by a select team or a small group just within the transplant. This is going to require establishing very good, robust relationships and then maintaining them afterwards.